Order. We're a hop house to move the motion.
Thank you, Ms. Voss, and it's a pleasure to serve with you in the chair. I beg to move that this House has considered Eating Disorders Awareness Week 2026. Eating Disorders Awareness Week this year is centered on the theme of community. Over the past 6 years, as chair of the all-party parliamentary group on eating disorders, I have witnessed the power of community firsthand. Our APPG has grown into a determined group of MPs, campaigners, clinicians, researchers, families, and crucially, people with lived experience. I want to thank my colleagues across the House who continue to work constructively on this issue. I also want to pay tribute to Hope Virgo, our tireless secretariat, who has turned lived experience into sustained strategic campaigning. And of course, I want to thank BEAT, the eating disorder charities, without whom their tireless campaigning on this issue, the Eating Order Awareness Week wouldn't even be coming to this Parliament. And yet, despite the tireless campaigning and greater awareness of this tragic illness, I must confess to deep frustration. Over these 6 years, things have not improved, they have worsened. The number of children and young people treating for eating disorders has risen by around 2/5 since the pandemic. The 2019 Health Survey for England found that the proportion of adults with a likely eating disorder has risen from around 6% in 2007 to 16% in 2019. Adults in England are waiting up to 700 days, almost 2 years, just to start treatment. Not only are we failing to treat people quickly enough, too often we are failing to identify them at all. Of the estimated 360,000 children and young people affected, only around 55,000 were identified by GPs in 2020, and even fewer accessed specialist care. Only a fraction of adults receive a formal diagnosis. This is a devastating reality facing eating disorder sufferers across the country today. That is why our APPG is calling on the government to introduce a dedicated national eating disorder strategy. At the last debate on this issue in September, the Minister for Care expressed concern about a proliferation of documents and strategies. He said he is not convinced that adding standalone strategies alongside guidance and plans will improve outcomes. Madam Chair, eating disorders are amongst the most complex and deadly mental health conditions. If ever there was a case for a dedicated, cross-departmental strategy, this is it. Without a unified strategy, we are left with fragmented guidance and piecemeal reform that fails to match the scale and seriousness of the challenge. So, I repeat that call today. It is time for a dedicated national eating disorder strategy. When we think of community, we often think of our friends, neighbors, and colleagues. But for many young people, community is no longer primarily physical. It is digital. And the community they encounter online often reinforces their problems rather than helping them to recover. Platforms are saturated with pro-eating disorder content. This includes misleading nutritional advice and distorted body image ideals. One alarming trend is these so-called recovery accounts. Rather than providing helpful advice to sufferers, they often share tips on hiding behaviors from staff or how to minimize meals. Research by the Center for Countering Digital Hate reveals something deeply concerning. When researchers simulated 13-year-old users on YouTube, the platform's algorithm recommended harmful eating disorder content in 1 out of every 4 videos they watched. 1 in 4. It gets worse. When these harmful videos were reported, nearly 3/4 of them were not removed. Even after being flagged, most of this dangerous content stayed online. This is not simply about individual users. It is about algorithms amplifying harm. A single pause on a video can trigger a stream of increasingly harmful material, even when users block accounts or report content. Similar posts rapidly reappear under new hashtags. In September, the Minister for Care rightly acknowledged that the government must address the underlying drivers behind the rise in eating disorders, including the online environment. I welcome that recognition, but I'm concerned that he pointed to the Online Safety Act as an example of how this can be addressed. After the global ban of @Skinny Talk, new hashtags emerged almost immediately, after which the same harmful content was posted. We must focus on the algorithms that amplify harmful content. And the government, through Ofcom, must hold social media giants to account when their platforms repeatedly allow harmful content to circulate. Relying on the victims of such content to continuously report and become the regulators cannot be right. If there's one lesson the APPG has learned over 6 years, it is this: eating disorders are profoundly misunderstood, and this misunderstanding costs life. Early warning signs are often missed, leaving families to navigate complex and frightening conditions without guidance or support. That lack of training translates directly into delayed recognition, unsafe discharge decisions, and prolonged suffering. In 2017, the Parliamentary and Health Service Ombudsman warned of avoidable death and systemic failings in NHS eating disorder services. It called for improved training, better coordination, and cross-organizational learning. 9 years later, Ms. Vast, we are still seeing the same failures. Across England, many of the specialist community eating disorder teams lack a consultant psychiatrist. Vacancy rates for consultant posts remain high. There's guidance available, like the Royal College of Psychiatrists' Medical Emergencies in Eating Disorders, but it is inconsistently applied. Where training is offered, it is patchy, inconsistent, and too often voluntary. Last year, I was contacted by the family of Ruby Hamill, a young woman with a history of severe anorexia nervosa. While held on remand at HMP Newhall, she collapsed after being unable to eat for almost a month. Despite her known history of anorexia, she received no eating disorder treatment in prison. She was later treated for refeeding syndrome, a life-threatening complication, after being granted humanitarian bail. Ruby thankfully survived, but she nearly died in the care of the state due to an absence of clear, mandatory standards and properly trained staff. Frontline staff need practical, evidence-based training. They must be able to recognize early warning signs and know how to ask sensitive questions, communicate without reinforcing harmful thinking, and escalate concerns safely. Proper training saves lives. If we are serious about tackling this crisis, we must equip frontline staff with the skill and knowledge they need to effectively help people. But training alone is not enough. Even the most skilled professionals cannot protect patients within a system that lacks clear, enforceable standards on timely access to care. For children and young people, there's a waiting time standard. 95% of urgent cases seen within 1 week and routine cases within 4 weeks. Yet this is not consistently met. For adults, there's no waiting time standard at all. Recent data shows median waits of 42 days, with some waiting many months, even over a year for assessment or treatment. During that time, physical health deteriorates and hospital admissions become more likely. Access to quality care is a postcode lottery. Only 1 in 6 integrated care systems currently provides sufficient intensive community or day treatment for both children and adults. I welcome the commitment to expand intensive community and day services, but we must not allow community care to be a pretext for the erosion of specialist inpatient units. Specialist inpatient services stabilize those who are critically unwell. They offer a range of expertise that community teams cannot always replicate. Yet we do not currently have enough specialist beds for the acute level of need we are seeing. At the same time, our research has found some deeply concerning discharge practices. Recent FOI requests to all trusts across the UK found that people with eating disorders are often being discharged at BMI of under 15, and in some cases far lower. I'm concerned we are discharging patients who are medically unsafe simply because beds are scarce. If community and day services are to succeed, they must intervene early and be properly funded so that everyone can receive quality care closer to home. When people receive timely evidence-based support, the need for intensive inpatient or day treatment can fall by around a third. That reduces risk for patients and long-term pressures on NHS services. We cannot solve this crisis by shifting care around the system. We must build capacity across the whole pathway. Early intervention, community provision, and specialist inpatient care, so that access is determined by need, not postcode. In October last year, Ms. Baas, our APPG published a report on preventing eating disorder-related death. It made for harrowing reading. While some areas of the UK showcase pockets of good practice, the evidence is clear that unsafe discharges are still far too common, and the system is failing to prevent avoidable death. People with anorexia are 5 to 6 times more likely to die than the general population, both through suicide and physical complications. In many cases, death from eating disorders are misrecorded or omitted from death certificates and instead attributed to organ failures or suicide. As a result, we do not even have exact statistic for eating disorder death, meaning the true scale of the crisis remains unclear. If we cannot even accurately record how many people are dying from this illness, eating disorders, how can we possibly begin to address the scale of the problem? The APPG has repeatedly called for a confidential inquiry into eating disorder death, similar to inquiries that exist for maternal death, so that patterns can be identified and lessons learned. We know what we need to do. We have a strategy plan, and we have experts through the APPG willing to support this work. In September last year, I asked for a follow-up on what the department is doing to ensure that eating disorder deaths are recorded accurately on death certificates. I was promised an update from the Minister for Women's Health and Mental Health on progress in this area. I waited for weeks. It was only after I raised the matter in the House of Commons chamber that I eventually received a written response. That response stated that the issue did not lie with the Department of Health, but with the Ministry of Justice, and that I would be contacted shortly. Why did it take weeks to give me that information? That was in November, and I'm still waiting. I still have not heard from the Ministry of Justice. I appreciate that ministers face competing pressures, but this is about accurately recording avoidable deaths. It should not require repeated parliamentary interventions to finally receive an answer. So I ask the Minister today, when can I expect an answer? When will families receive the transparency they deserve? Eating disorders cost the UK an estimated £9.4 billion annually in 2020. Just the cost for the NHS. That's not even the cost a whole, the cross of the range of what eating disorders cost us as a society, the costs to life, to family, the stress of years and years of waiting for treatment or being finally successfully treated, if at all. Yet between 2015 and 2019, eating disorders received only around 1% of UK mental health research funding. We are spending billions managing the consequences while investing a fraction in understanding causes and improving treatments. We cannot reduce long-term costs if we continue to underinvest in research. In line with the government's focus on early intervention and prevention, this must change. Madam Chair, the eating disorder community is strong. It is passionate. It is determined. Our goal is to grow the community beyond those already engaged, to reach those who do not yet recognize the symptoms, to engage those who think this is someone else's issue, because it is not. No one should be dying of an eating disorder in 2026. No parent should be forced to fight the system while fighting for their child's life. No person should be told they're not ill enough to deserve care. We need a dedicated national eating disorder strategy. We need sustained and proportionate research funding. We need mandatory workforce training. We need a waiting time standard for adults. We need accurate death recording and a confidential inquiry into all eating disorder-related death. And we need stronger online regulations. We know what needs to change, and the APPG stands ready to work constructively with ministers to deliver it. There is no time to waste. Thank you.
Can I just say if anyone requires any assistance during the course of this debate, please see the doorkeeper. The question is that this House has considered Eating Disorders Awareness Week 2026. Jim Shannon.
It's full. It's always a special pleasure to serve under your chairship. They always do a Thursday afternoon, and by and large I seem to be here, but that's by the way. Some people say, well, where else would you find them, but there you are. Can I say it's a real pleasure to follow the Honourable Lady for Bath. And the time the Honourable Lady's been here, she's been very much a real hard advocate for this issue, and I think every one of us recognises her commitment and indeed her leadership for this matter as well. And I want to put on record my thanks to her for what she's done and what she continues to do, and indeed, if God's pleasure, what she will continue to do for the future as well. And it's really important.
Can I ask you to speak up a little? Because I think we're not really here in the public gallery. Jim, is that okay, Mr. Shannon?
I don't think I need to do the introduction again. We'll leave it at that. Can I just say that I want to tell a story as my introduction. I want to tell a story about an Honourable Lady knows this story of one of my constituents. I was elected in 2010, one of my constituents in 2012. I knew her mum and dad extremely well. They were both police officers. I knew them from a friendship that we had outside of the police, but also because they were police officers that I had contact as an elected representative for a period of time. They had a daughter. I'm not going to mention her name. I'm not going to mention their names either. And she had severe bulimia, and she was a lovely-looking young girl, by the way, very bright, but she had a real problem. What happened? Because it's a true story of the journey that family had. They came to me worried sick about what was going to happen with their daughter, what they could do, and perhaps what could be done. And the fact of the matter was, I, along with them, approached the Health Minister in Northern Ireland. At that time it was Edmund Putz, my party colleague, and told him the story. We didn't have anything in Northern Ireland to address the issues of eating disorders, and therefore we had to come here to do that. But I remember meeting the parents in Central Lobby in 2012, and they were able to tell me that the Minister in Northern Ireland, Edmund Putz, had been able to transfer that young lady to St Thomas's Hospital that way, and were able to give the help that young lady needed. It's a transformational story, Madam Chair, because what they did by doing that, they saved that young girl's life. Didn't just save her life, because I know her well, and indeed I was canvassing one day down on the edge of my constituency in the Lisle, and I knocked the door, and there she was, 2 young children, and that intervention by the Health Minister in Northern Ireland helped save her life and give her a life for the future. So it's an example of what can be done if everyone can work together to ensure that things go the right way. I also unashamedly say, Madam Chair, that there was down to the NHS intervention, but the prayers as well of God's people undoubtedly saved that young girl's life. And I want to discuss the situation in Northern Ireland. I'll give you that example because it's a combination of how we worked in Northern Ireland here with the health service here, and ultimately to give that support for that young lady to start her life with her husband, and ultimately with her husband and then with her children. Official figures show that people referred for eating disorder support in some areas face significant waiting times, with people experiencing delays as a part of broader pressures on mental health services. And sometimes the issue, the Honourable Lady from Bath in introduction referred to the mental health issues in her introduction, and those are some of the things you've got to try and overcome. When I say you, I mean collectively. I don't mean you, Madam Chair, specifically. In addition, mental health waiting times have been deemed unacceptable, and there has been a failure to publish comprehensive waiting time data. I don't know my health debates I don't do, Madam Chair, where the issue of data is so important. The data tells us the direction we need to go. The data tells us and gives us the evidence to put together a programme of response and to help ensure that we can find a better way of doing things. It also gives the waiting time data, especially for CAMS, which is critical in supporting young people, and more often than not, it is young people. I'd also like to raise the impact that social media is having on people who suffer with eating disorders. Furthermore, we have seen in the last year a drastic rise in advertising around weight loss jabs and accessibility to them. It is fair to say that they're easy to get, they're easy to use, they're somewhat affordable, and they give a quick fix or change. Whilst the premise of weight loss injections is good and intended to help those get to a healthy weight, for those with eating disorders, they have the potential to undermine awareness of healthy nutrition, of exercise and mental health support. And it's very important sometimes that they're not seen as another way of trying to get that perfect body, if I can use that terminology. Social media can be toxic enough, Madam Chair, and I worry very much that the young girl are really struggling with the likes of anorexia or bulimia, idolises the perfect body through weight jobs, etc., and almost dies trying to get there. Again, if the Minister is able, if I don't mind asking this question, in relation to, is there control or any control over those who can have the weight loss jobs, and therefore you can have a better idea of what their intentions are, or maybe some of the problems that they may be having? Many advertisements do not adequately convey medical risks, the contradictions, or the need for supervision, leading vulnerable users to try treatments unsafely. Those with eating disorders may misinterpret these ads as a safe method to lose weight quite quickly, increasing the risk of physical and mental health complications. And Madam Chair, in Eating Disorders Awareness Week, which we're in, and which the Honourable Lady has very kindly given us a chance to participate in this debate, reminds us that behind every statistic is a person. I give an example of that young person that I knew and the success story. And there's many others that are success, but sometimes there's those, perhaps, with sadness we record some of those things that maybe people don't make it. In Northern Ireland, long waiting times, limited specialist services and rising demand mean too many people are not getting the help when they need it most. At the same time, toxic social media content and relentless pressure to conform to unrealistic body ideals are fueling the anxiety, the low self-esteem and the harmful behaviours, particularly amongst young people. So the Minister's here, and the Minister, in the time I've got to know him through these debates, has always been very responsive to our requests. So again, I give our request to the Minister. There is a lot of pressure across all the United Kingdom for the issues of anorexia and bulimia. And has the Minister had a chance yet, in the short time he's been in post, to have a discussion with the Health Minister, Mike Nesbitt, back in Northern Ireland, to discuss maybe how we can better work together to try and address these issues? I'm very conscious that most of the treatment probably happens here, so therefore they can do some, but they can't catch and keep up with the level of problems. So I look very much to the Minister for his commitment to ensuring those struggling can access the support that they need, both here in England and indeed further afield in my own Northern Ireland. Thank you so much.
Got Arthur.
Thank you, Ms Vaz. You won't be surprised to hear it's a pleasure to serve under you today. And I do want to thank the member for Bath for the way she introduced this debate, and also for her leadership on the eating disorders APPG. And I want to join her as well in thanking Hope Virgo for all the work that she does. In many ways, eating disorders can be a hidden condition and even a secretive condition, but I really do think that Hope really does give it the publicity that otherwise it wouldn't get. And Hope has been through a lot, and I wouldn't wish what she's been through on anyone, but we are lucky that she is the campaigner that she is. I'm happy to give way on that point.
It is probably also worth mentioning all these many people who have come forward to bravely tell their stories and to raise awareness, to take away the stigma. Each time they come forward, we know how much courage it takes to come forward, and I want to sort of thank collectively everybody who does that. We need more people to come forward, talk about their experiences, but thank you to everybody who has come forward.
Yes, absolutely. And I don't attend the APPG as much as I should, but where I do attend, people can tell amazingly personal stories about both what's happened to them, their position as survivors, but also people who have lost loved ones. And it can be very emotional for people, but it's really important that we share these stories and these experiences. And I also want to thank the member for Isle of Wight West, because I think he's been a fantastic champion as well in the House of Commons. And I'm really surprised he's not here. I really expect he's got a good reason for not being here, and maybe I'll be watching just now. But I want to focus on community, and I think through the APPG we are trying to create that sense of community as well, and the role that plays. So we all accept that having proper community support is hugely beneficial to those with mental health issues generally. And through the membership of the APPG and my work as an MP more widely, Ms Vaz, I have become much better informed about what community looks like around those with eating disorders. The support of a community, whether it be a family, friends, school or support organisation, is a wonderful thing for anyone struggling with their mental health. So often it is the first support network that someone will reach out to, families and friends that catch their loved ones in those most difficult times. Community care is also often the best approach to eating disorder care, but beats There Is No Place Like Home report highlights the importance of expanding access to intensive community and day treatment for eating disorders. In many cases, this could be a lifeline for those struggling, avoiding them being sent to treatment facilities some hundreds of miles from their homes when they can actually access a support network nearby. However, effective community care can seem like a long way off when existing services for eating disorder treatments are so stretched and right across the UK. And particularly with this Minister here today, I do want to talk a little bit about Scotland. The crisis in young people's mental health care in Scotland is acute. CAMS, the service in Scotland, is overwhelmed. And every week I have constituents who are contacting me about difficulties they have in accessing CAMS. And my staff have to tell me to be very careful not to raise the expectations of people, because the service is so overwhelmed. And I've met the staff in CAMS and they are working so hard, and I want to pay absolute tribute to them. They just need more resources. I spoke to the Chief Executive of NHS Lothian specifically about the support for people with eating disorders. And she was very frank. She had just come into post and she said that she thought the service was at the absolutely minimum acceptable level. And, you know, perhaps I shouldn't have welcomed that, but I did welcome it, because I think the starting point for fixing a broken system is to accept it's not working. And I welcomed the fact that you didn't try to gloss over it. And since I'm happy to give way again.
He's very generous. Is it not true that the mental health toll on the people who are working in eating disorder services, knowing that they cannot provide an adequate service to many people who suffer, is also a big consideration that we should have? You know, what are we doing for people who are working in these services, who know they would like to be the best they can, but simply cannot because of lack of resources?
I mean, absolutely. I mean, the workforce plan hopefully is key to resolving this. But I don't know an area in the NHS that has too much staff and wants to redistribute it. But it is a huge challenge, and it's something we have to address. But again, the starting point to acknowledge there's an issue and actually offer those staff support where we can. And the reason I raised this with the NHS Lothian Chief Executive was partly me exploiting my position, because I had a close family member who had been dealing with an eating disorder, and she was given an appointment to meet the service. And I was so frustrated because it was months and months and months into the future. But I waited patiently. I'm a patient person. And but as we got closer and closer to that day, my hope built up, and it built up, and it built up. But when we reached that day, my loved one went for the appointment, and it was merely just an assessment of whether or not that person needed proper support. So felt completely deflated, actually. And so hopefully people aren't still going through that. So in these terms of crisis, it is all too often communities and families that are left to step up to provide what care they can. I've met parents in my constituency who are doing their absolute best. they can for their children. And I did meet one woman, another anecdote I'm afraid, Ms Vaz, who she told me how her daughter was so weak that she had to phone an ambulance to take her into hospital. And when her daughter got to hospital, the medics said that she was too weak to remove her from the ambulance, and they had to treat her in the ambulance. And again, it's this nature of the condition. Often they can be very secretive and very hidden conditions until it's hopefully not, but until it can be too late. But it's not enough. Sorry, I've lost my plot here a little bit. But this is often not enough, the support of families, and professional medical help is required. Both the UK Government and the Scottish Government must go further to ensure that treatment is more readily accessible for those who can no longer rely solely on the support of their loved ones. And I will come back to that. However, when considering the idea of community around eating disorders, we must also consider the online world and its ability to create a space for more dangerous communities. Pro-eating disorder content, as we've heard from the member from Bath, does exist across the internet, from independent forums to social media sites that we all use daily. These groups or posts provide what is called thinspiration, tips on how to starve yourself or make yourself throw up. They glamorise the awfulness that eating disorders are, introducing them to previously where children and young people might not have even considered them, exaggerating conditions and sometimes normalising them. This became particularly concerning during the pandemic, where I think we also seen a massive growth of eating disorders within the male population, as many young people were left isolated from their peers and turned to online communities. Instead of support, all too often they found content that damaged their mental health and isolated them further from the people around them. It is hard to understand just how disturbingly common this sort of content is. Figures from April 2025 show that more than a quarter of young people have been exposed to eating disorder content online. This is likely an underestimation, as it sits alongside the 1/3 of children who are seeing self-harm and suicide content online as well. Social media sites are feeding young people this content from the never-ending algorithm, which we've heard about again from the member from Bath, and more children are likely to consume the content because of social media. The more and their algorithms, and the more they will continue to see it, the more they consume it, and the more they consume it, the more they'll continue to see it, creating a greater and greater relationship with these harmful online content, with these harmful online communities. The proliferation of this content is the result of passivity from the tech firms, and in part their profit motives. One study showed that Meta derives a profit from around $2 million from pro-eating disorder content on Instagram. With content creating profits like this, it's hard to see that social media sites would have ever self-regulated to ensure it was hidden from children. And I did meet Meta this week, actually, not to talk explicitly about eating disorders, but to talk about the proposed ban on social media for under-16s. And I can see it's something that they feel challenged by because they're concerned about a loss of income, basically. Not loss of income from young people, people under 16, but about losing them as users as they move into adulthood. But I do think, and I hope, perhaps blindly, that there's an opportunity to work with these companies to make sure this ban works properly. I mean, I'm really supportive of a ban on under-16s accessing social media, and I know my constituents are as well. And I think we also have to work with charities who work in this sector to make sure the ban absolutely works as well. But I also want to talk about the Online Safety Act. So I do welcome the Online Safety Act and its commitment to ensure that at least that children see less of this harmful online content. Many constituents have contacted me since the summer raising concerns about the Act and what it means for how they use the internet as adults. Often men, you might not be too surprised to hear. And I do understand the wider flaws, which I think were introduced by the member from Bath in her speech. She talked about their impact. But so whilst it's not perfect for eating disorders and suicidation content for children and young people, I do think it adds quite a lot of friction, and it does make it quite harder for young people to access that content. So not perfect, but definitely a step in the right direction. So it's a key part of protecting young people and reducing their exposure to harmful content, including eating disorder content and other negative influences. And one last anecdote you might be glad to hear, Ms Vaz, is that when I was Googling on the train this morning this topic, I was really pleased to see that every time I tried to Google content about eating disorders and what government policy was, etc., Google was very good at putting a warning in place and saying to me, I might want to phone this helpline, or I might want to contact this service to talk about eating disorders if that was something. That's why I was Googling. So I was really impressed by that. So it's a really good example of how quite often tech companies are the bad guys, but I think they can do good stuff as well in this space. So we must continue to ensure that communities supporting those with eating disorders are supported by proper medical care where necessary, and also support with communities. And we must do all we can to remove that harmful content. So I'm sure this is not the first time the Minister's come to one of these Westminster Hall debates, or even debates in the main chamber, where he's been asked for a strategy, more staff, and greater clarity about what the governments do. But I know he does care about this subject, and I know the government is doing work in this area. I do think the call for a strategy does make sense, because I think whilst the government is doing things in this area, I think a strategy would help put it together and help give us some clarity about the next step. So I really do look forward to the Minister summing up. Thank you. Thank you.
Ollie Glover.
Thank you, Ms Vaz. It's a pleasure to serve under your chairship. And can I thank my honourable friend, the member for Bath, for introducing this debate, and indeed for her enormous dedication and hard work on this vitally important issue for many years. I'd like to talk about some of the themes that arise from constituents' cases that my team and I have encountered and supported. And I think the key theme is that the key concern isn't the clinical care and the clinical aspects, but more the delay and fragmentation of the ownership of care. Life-threatening conditions can drift. Gaining access to care, support and treatment often involves a Kafkaesque labyrinth of dysfunctional process and procedure, and referrals and re-referrals between a range of teams in the very complicated organisation that the NHS is. There is a real need for independent specialist assessment, safe interim arrangements, and timely and accountable coordination of care. Some people wait more than 8 months for an answer either way as to whether they are eligible for treatment under the current criteria, which of course can further compromise their confidence in coming forward and asking for that support. This can have a huge personal cost, impacting people's ability to drive or be able to work, reducing life expectancy, and of course creating long-term medical complications which add to wider pressures on the NHS. So as with other debates that we have about healthcare in this country, this is perhaps highlights another area where if we get a start of the process right and those early interventions and those preventative interventions, we can help not only the individuals but to alleviate some of the pressure that is in critical care services.
Will you give way?
I give way to my honourable friend.
It is also worth mentioning again and again and again, with eating disorders, the longer you leave treatment, the longer it takes, and I think there's a sort of exponential of three times as long it takes to recover than what you have suffered. If you've suffered from an eating disorder for 3 years, it takes 9 years to fully recover. And these things are particularly pertinent to eating disorders. So we know from other health services early intervention is key. It is particularly important for eating disorders because the longer you leave it, the much longer your recovery process is. And some people never recover, and it is a life sentence.
Well, I thank my honourable friend for her intervention, and she again shows her wealth of knowledge and experience of this topic. And indeed, some of the cases that my team and I have supported have involved people who have been living with eating disorders for decades. I've also seen cases where, and this is not unique, of course, this is a wider issue with mental health provision as well, where the transition from children and young people support services into those for adults can be managed very badly. And as we have heard, eating disorders can have a devastating impact. They rob people of years of life, wipe out adolescence, and remove educational and social opportunities and leave many isolated and unable to cope. Eating disorders are one of the deadliest mental health conditions and constitute a significant health crisis. And we have seen cases of eating disorders having surged, with hospital admissions doubling, in a decade. And it is a huge concern in the face of that crisis that eating disorder services are being cut in much of the country. Over half of the country's integrated care boards have cut real-term spending on children's eating disorder services in the last financial year. I'm proud of the leadership that parliamentarians like my honourable friend, the member for Bath, and Baroness Parminter in the other place have shown on this issue, including working with campaign groups such as Dump the Scales. The scandal of people being told that they are not thin enough for medical help must end. Far too many people cannot access the services they need. So I welcome recent guidance from NHS England on how to design eating disorder services to support children and young people better. But we need to do more than tinkering around the edges with updated guidance. We need a meaningful national strategy to transform these services with more specialist support and to build a culture across the health service and beyond that recognises the complexities of eating disorders and the terrible dangers they pose. And what lends real urgency to that is that the target of 95% of urgent cases receiving treatment within a week and routine cases within 4 weeks is routinely being missed. From September to November of last year, only 78% of urgent referrals and 82% of routine referrals started treatment within the target timeframe. And that's why I'm also very, very happy to support a wider Liberal Democrat campaign for investment in community health services and prevention, including better specialist support for people with eating disorders. And as we've heard from my honourable friend, that early intervention can greatly reduce the number of people we are suffering. We're also campaigning for regular mental health check-ups, the concept of a mental health MOT, at key points in people's lives when they're most vulnerable to mental ill health. Like others who have spoken, I very much look forward to hearing what the Minister can say on this, because so many people are suffering and lots of people are trying. I don't think that's the issue. It's about how can we make that overall system work much better with all of its different component parts, all aiming towards that goal of supporting people.
Helen Morgan.
Thank you very much, Ms Vaz. It's a pleasure to serve with you in the chair. I would like to start by thanking my friend, the Honourable Member for Bath, for securing this debate, for her dogged campaigning and her tireless work as chair of the APPG on eating disorders, and her excellent speech opening this debate today. I welcome Eating Disorder Awareness Week and the important role it played in drawing attention to one of the deadliest and most harrowing of conditions. I'd also like to recognise and draw attention to the invaluable support that the eating disorder charity BEAT offers for those with an eating disorder and the carers and healthcare professionals who support them. In many cases, this can be life-saving. Because anyone with personal experience of eating disorders will know just how devastating they can be. Eating disorders rob young people of the formative years of their life, put immense strain on families and carers, and have long-lasting physical and psychological impacts. I was shocked to learn that hospital admissions for eating disorders have doubled in the last decade. A development as stark as this demands robust action and investment. And at the same time, over half of the country's integrated care boards have cut children's eating disorder services. And children and young people can't be allowed to slip through the net because of underfunded services. And research by the National Audit of Eating Disorders has found huge disparities in the levels of support available for children compared to adults with eating disorders. Adult community teams face an 89% higher demand than teams supporting children and young people, with adults waiting twice as long for assessment and over 10 times as long for treatment. For a condition that progresses devastatingly quickly, early intervention is crucially important. While the Liberal Democrats welcome NHS England's recent guidance on the improved design of eating disorder services and community-based support, this support cannot fulfil its potential without investment and a meaningful strategy to tackle the problem. And I add the calls of my party to those of the people who've made excellent speeches in this debate today. In Shropshire, I was pleased to see recent improvements in waiting times for children and young people awaiting treatment for eating disorders, with 96% of patients seen within 4 weeks. And that's come from a fairly low standard, so that's a huge improvement, and I congratulate everybody involved with that. However, a quarter of children and young people referred to mental health services as a whole didn't receive contact within the 4-week waiting standard. 19% of referrals for appointments were not seen within 18 weeks. These waiting times are unacceptable. Urgent mental health problems are exactly that, they are urgent. Time is of the essence when tackling an eating disorder, and delays in assessment and treatment carry serious dangers. I know from constituents who've gone through the process of trying to access treatment for their own children just how difficult it can be to get support on time, because services are underfunded, waiting lists are long, and resources are stretched. I've heard from parents whose daughters' conditions weren't deemed serious enough to be referred to an eating disorder clinic, despite having a dangerously low weight in BMI. They were told, essentially, that she needed to be thinner. I don't need to explain just how problematic it is to imply that someone's condition must get significantly worse before they can be seen. One mother's tale of struggling to get support for her daughter is too harrowing to report here, but her cry for help speaks volumes. Please help us. I am scared and desperate. For patients who do access treatment, gain some weight and are discharged, many are not given the continued mental health support to prevent relapses of the condition, and this can't go on. We must also not underestimate the impact of eating disorders on entire families. Patients require around-the-clock care in many cases to ensure that they receive the support and nutrition they urgently need. One self-employed single mother who wrote to me about the delays and failures she had encountered when seeking support for her daughters had to forgo her income to care for them. We need far better support for unpaid family carers who are struggling to support their loved ones with eating disorders and must ensure that they have the training and advice they need to be able to provide the help that's so urgent. The government's primary course of action for easing this burden should be to provide patients with the support they need when they need it. And that's why Liberal Democrats are calling for proper investment in community mental health services, prevention and specialist support for eating disorders. We are campaigning to establish mental health hubs for young people in every community, a dedicated mental health professional in every primary and secondary school, and regular mental health checkups for the most vulnerable. Our debate on Tuesday on our opposition day called for action to ensure that cinema-style age classification ratings are applied to social media sites to prevent children from being subjected to the worrying proliferation of harmful content promoting eating disorders, which, as we've heard today, can be so pernicious and damaging. And I would urge other parties in this place to put aside the politics of that and support the calls supported by many children's charities to ensure that an appropriate safeguarding regime is put in place for children's use of social media. The government must improve early access to mental health services so that cases can be caught early before they become critical. Can the Minister commit to preserving the mental health investment standard and reinstating targets for the treatment of mental health issues, especially for young people, so that we can do that? The stories we hear of families and patients' experience of eating disorders are heartbreaking. We must treat these conditions with the urgency they deserve. Thank you.
Thank you, and it's a pleasure to serve under your chairmanship this afternoon. I'd like to congratulate the Honourable Member for Bath on securing this very important debate today and for her work in this area. Eating disorders are deeply complex conditions. On the surface, disordered eating can take a variety of forms, including restricting the amount of food eaten or the type of food eaten, by binge eating large amounts of food in a short period and purging that food through enforced vomiting, excessive exercise or laxative misuse to avoid weight gain. And beneath that surface lay a hoard of drivers such as control, shame, anxiety, obsessive-compulsive disorder, poor body image, and misophobia, which is also known as germophobia. It comes as no surprise that the COVID pandemic, which provoked intense scrutiny of germs and cleanliness, a lack of control, took away control from people when they could go out, when they could see their friends. It drove people's activities from the personal to the online, saw a spike in eating disorders referrals. And by early 2021-22, 3,400 people were treated for an eating disorder compared to the same period in 1,900 people in the same period in 2019-20. Madam Chair, the last government introduced the Mental Health Investment Standard to increase mental health spending in local health systems. It also included a pledge to increase mental health spending as a proportion of total health spending every year, with mental health accounting for over 20% of demand for health services, and a 2021 report finding eating disorders cost the UK economy £9.4 billion per year. Sorry. Okay.
Thank you.
The last government's work to channel more resources into mental health couldn't have been more welcome. 2025-26 will be the first year since 2016-17 that mental health spending has not risen as a proportion of health spending. This is a contravention of the Mental Health Investment Standard, which has raised alarm bells at the Health and Social Care Committee in this House. Can the Minister enlighten us why the government has decided to break their mental health investment standard after nearly a decade of progress? Does he think the percentage is now about right as a proportion? Does it concern him that some ICBs have cut funding for mental health services? How does he expect this to impact on patients suffering from eating disorders? I'm particularly concerned is the impact on children and young people, and I should declare an interest, Madam Chair, as a consultant NHS paediatrician. 6.4% of adults have a diagnosed eating disorder, but that rises to 12.5% of 17 to 19-year-olds having been diagnosed with an eating disorder since 2023. That amounts, Madam Chair, to 1 in 5 girls in this age group, 4 times the prevalence in boys. So what specifically is the Minister taking action to improve early intervention? The last government got the ball rolling on establishing mental health support teams in schools and had 35% coverage by the time of the general election and a commitment to increase that to 100% of schools and colleges in England by 2030. Does the Minister plan to build on this work? What further action is he taking to improve links between eating disorder services, schools and families to ensure a joined-up approach to accessing specialist help and the early diagnosis, which, as we've heard, is very critical? The Honourable Member for Didcot and Wantage spoke of the challenges of transition, and I see as a paediatrician that there are challenges in transitioning of many paediatric and adolescent conditions between the children's and the adult services. But if the Minister could say what specifically he's doing for those transitioning with eating disorders. Madam Chair, in my role as Chair of the All-Party Parliamentary Group on Emerging Drugs and Online Behavioural Trends, I know the effect of social media on children's and young people's behaviours. Research in University College London examined evidence from 50 studies in 17 countries and found that social media usage is linked to eating disorders in young people by viciously promoting the idea that it's essential to be thin and fit, triggering a potentially extreme preoccupation with body image, weight and shape. These obsessions are compounded by AI content which can depict simply unachievable so-called perfection. There are harmful videos online, as a member for Bath says, with algorithms driving that harm. For those who look at it, get to see it more and more and more. A recent policy debating competition that I held amongst Year 10 and 12 students in my own constituency, Madam Chair, where the students chose the topic of debate themselves, found that many of them spoke in favour of a social media ban on children as young as 16. It's difficult, it's not a perfect solution. I do wonder myself, having just got a new mobile phone, why when you buy a phone it can't be set at an age that's fixed and only changeable by the adult that pays the bill. But I think a change in the law to restrict social media to from under 16s would help to reduce this problem. Interested in the Minister's thoughts on that. One thing that's been raised in the debate already is the NHS guidance for ICBs on eating disorders. They've refreshed the guidance, which is welcome, but patients will only feel the difference if it's actually implemented. The Minister has confirmed there won't be a dedicated strategy for eating disorders, and there's no mention at all of eating disorders in the 10-year plan, the 70,000-word 10-year plan. Is the Minister confident that this refreshed guidance for ICBs is going to be sufficient on its own to improve care for people with eating disorders and get the waiting lists down, or does he have a strategy for how it's going to be enforced? And we've talked today about the effects on families and carers. What action is the Minister taking to engage family and carers and supportive charities in the care and plans for care, and what support is available for parents, for carers, and indeed, Madam Chair, for siblings? Workforce is key in delivering this strategy. We know that waiting times for eating disorders are getting worse, and analysis from BEAT found that people with eating disorders face a 3.5-year delay in some cases between falling ill and starting treatment. For someone with an eating disorder, that's 3.5 years deeper into the illness, and as we've heard, that makes it all the more difficult to treat the patient effectively and to quickly pull them out of that difficult, dark place. What steps is the Minister taking to increase workforce capacity to help treat these patients and restore some stability and normality to their lives? And I feel like I ask this question every time, Madam Chair, but the NHS long-term workforce plan is still not with us, having been delayed from last year. So when will it be published, and what tangible action will it take to boost the NHS eating disorders service? It's not just about hiring more staff, though, it's also about where we're hiring them. This is important work, but more needs to be done to build on the progress. The Healthcare Quality Improvement Partnership, HQIP, produced a highly detailed report about inpatient eating disorder service provision in the UK. As expected, there were black spots for these vital services in many rural and coastal areas and places such as Lincolnshire. For adults in families and constituencies like mine, where the closest service may be an hour's car journey away, accessing eating disorder services is remarkably difficult. The government has been insistent that rural and coastal areas will not be left behind on healthcare, but black spots would tell us otherwise. Online and television... I will go by that point. Yeah.
I do thank her for giving way, and I have to say she is one of my favourite Tories. But there's a real inequality here, isn't there? Because a 1-hour car drive is a challenge. But if you don't have a car, it's even more difficult. And if you've got a child, say, you might have to take a day off work to take them to somewhere. So getting services closer to people, or capacity in the community closer to people, should absolutely be the ambition, shouldn't it?
I agree with the honourable gentleman completely, and he is right. And it's not just people who have a car. Of course, some people who do not have a car and are reliant on public transport, it can be even more difficult. People who struggle to take time off work because of the financial cost of it, and the cost of it, even of the petrol for those who do have a car or diesel to get themselves to the appointment. So if the Minister could update us on what he's doing to ensure that the neighbourhood and community slant of his 3 pillars of his health improvement are working in that regard. Inpatient services, as the Honourable Lady for Bath said, are limited in capacity. And I've seen in my paediatric practice patients waiting on acute general paediatric wards, which are really not the right place for these patients to be cared for several weeks at sometimes. And I wonder what he's doing to, if you could update the House on what he's doing about increasing capacity in the regional services. I'd like, if I may, Madam Chair, to speak a little bit about 2 other types of eating disorder, ARFID and PWS. ARFID, avoidant restrictive food intake disorder, involves limiting the amount of a variety of food consumed. This is not just picky eating. I've seen a teenager who lives on just simply plain pasta, nuggets and chips, and indeed a younger boy who lives on one flavoured brand of one milkshake and no solid food at all. This can be driven by fear, sensory issues and other issues. But what is the Minister doing to make sure the services are available for these people, these young children? NHS England's refreshed eating disorder guidance recommends that ICB should develop and deliver ARFID care pathways. What steps is the Minister doing to improve early diagnosis of ARFID, and what work will be done to train primary carers to identify ARFID in children and adults, particularly in cases of neurodivergence? Prader-Willi syndrome is a rare genetic disorder causing excessive appetite and overeating, which can lead to dangerous weight gain and restricted growth. Around 2,000 people are living with Prader-Willi syndrome in the UK, and there is no cure. It's not mentioned in the NHS guidance, so what work is the Minister doing to ensure that people suffering from PWS have access to the care they need? What steps will be taken to expand genetic testing at birth to identify PWS and improve early access to treatment for these patients? To sum up, Madam Chair, mental health challenges are on the rise and eating disorders are no exception. I urge the Minister to implement a clear approach to tackling eating disorders for adults, for children and for young people. Thank you, Chair.
Minister Dr. Zabir Ahmed.
Ms Vaz, it is an honour and a pleasure to serve under your chairmanship. And can I start by congratulating the Honourable Member for Bath for not only securing today's debate and raising this important topic as she always does, but also thank her and pay tribute to her long-standing advocacy on this topic and for all the work she does in the all-party group on eating disorders. She's joined Ms Vaz by a number of members across this House today who have made some thoughtful contributions, and conspicuous by his absence, and already has been mentioned here before, and I did inform him in advance I would mention him again, is my honourable friend, and he is my friend, the member for the Isle of Wight West. And he is conspicuous because of the tireless work that he does, how he advocates for persons with eating disorders, born out of, I know, personal interest and pain, and we miss his presence here today and send him our good wishes from across this House. Ms Vaz, it is important that we're having this debate today to note Eating Disorders Awareness Week. This year's theme rightly places the focus on the power of community, which speaks to a simple but profound truth. No one should face an eating disorder alone. Recovery is not only about clinical treatment, vital though that is, it is also about the networks of support that surround that individual, health professionals, but of course also mums, dads, grandparents, siblings, friends, teachers, colleagues, and much more.
I thank you for giving way. One of the most harrowing things that we hear when we take evidence in the APPG is again and again how families feel completely abandoned, how people have to give up work, often over years, because they are meant to care for a severe condition for which they do not have the capacity to do themselves, only for finally, when the condition is so bad that a loved one is being readmitted to hospital. That revolving door must end. The human cost to that tragedy, apart from the cost to the NHS, must end. It's absolutely tragic and it is wrong.
grateful to the Honourable Lady for her comments, and I wholeheartedly agree. In many conditions, and this is an exemplar in many ways, the revolving door is something that this government is committed to ending by joining up care, joining up streams of information that underpin that care. And that's one of our main commitments in our 10-year health plan, to have more joined up care, to move it from sickness to prevention, but also from hospital into community where that join up can happen. Ms Vaz, we know that this community can only thrive when it is built on a foundation of timely, effective care. That is why we are focused on reforming eating disorder services so that people can access help when they need it, not after their condition has escalated, as we have heard today. This approach underpins the new NHS guidance for children and young people's eating disorder services published last month, which is clear that care should be timely joined up and delivered as close to home as possible. As many here know, demand for mental health support, including eating disorder services, has risen sharply in the pandemic, and that rise has been sustained thereafter. And whilst services remain under significant pressure as a result of the additional investment, there are some green shoots in system capacity and capability to better meet rising demand and reduce those weights that honourable members have described today. In December 25, 83.3% of routine and 78.8% of urgent referrals to children and young people's community eating disorder services started treatment within 4 and 1 weeks, respectively. This is a marked improvement in performance compared to the 6 months earlier, when in June of last year, only 72.2% of routine and only 63.7% of urgent referrals were seen within 4 and 1 weeks, respectively. While these are encouraging signs, we are under no illusion, I am under no illusion, that too many children and young people are still waiting far too long for support, and this is exactly why further reform and delivery is needed. The government's long-term approach to mental health reform is set out in the 10-year health plan. That plan is clear in its direction, shifting care from hospital to community, from sickness to prevention, and of course from analogue to digital, which will have so much to do when it comes to having that joined up care too. Those shifts are not abstract principles, I can reassure the House. They are practical changes that are already being embedded, and I know that I know matter deeply for people living with eating disorders and for the families and loved ones that support them. But I recognise that plans alone do not deliver care. Delivery depends on people and having the right workforce with the right skills in the right places, and that is why, on top of the workforce plan that will come to fruition in late spring, early summer, we are investing in the workforce with a commitment to providing an additional 8,500 new mental health professionals across children and adult mental health services to cut waiting times and to ensure people access treatment and support earlier than ever before. We are also, Ms Vaz, working to strengthen skills and capability across the system. NHS England has introduced comprehensive training in place to make sure staff across both mental and physical health services can recognise eating disorders early and respond then safely and effectively. This training supports clinicians, not only working in the community, but also primary and, crucially, in acute care settings where I used to work and often saw patients such as this in my acute general surgical receiving ward rounds. This training includes specialist programmes, including the Royal College of Psychiatrists, Eating Disorders Credential, expanded access to family-based therapies, cognitive-based behavioural therapy for eating disorders, and dedicated training, as my honourable friend opposite mentioned, on ARFID. Together, this work is about giving staff the skills, confidence, and crucially, I think, the clarity they need to deliver safe, high-quality care and to reduce some of the avoidable harm that we have discussed today. I'm pleased, Ms Vaz, to say that funding for children and younger people's eating disorder services has increased significantly, rising from 46.7 million in 2017-18 to an actual spend of 106.3 million in 24-25. With this extra funding, we have focused on enhancing the capacity of community eating disorder teams across the country. We have focused on this because we know that timely, effective care leads to better outcomes, supports recovery, and helps prevent conditions escalating to the point where hospital admission becomes inevitable. Where admission is necessary, though, stronger community care can also reduce length of stay where it is safe. We recognise concerns that inpatient capacity remains under pressure in some parts of our country, including reports of individuals being discharged at very low body mass, as my honourable friend highlighted today, due to bed availability. Decisions about discharge must always be about clinical judgment and patient safety and not about capacity constraints. NHS England reassures me and continues to work with providers' integrated care boards to ensure sufficient specialist provision and safe step-down pathways will become in place.
His speech is very interesting. He talks about these increasing capacity, much of which will require workforce. When he mentioned the workforce plan, I noticed he said spring and or early summer, which is a change from his previous wording. Is that which has always been spring? Is that a sign that it's being delayed further?
Minister.
As always, the Honourable Lady reads too much into my words. I'm a Scot, so for me, spring and summer sometimes mean the same thing. And I can reassure, and indeed winter. But I can reassure her there was no subtext to that nuance earlier in my speech, and we remain committed and are on track to deliver that workforce plan. We recognise concerns, of course, and the NHS England is addressing them. Prevention, Ms Vaz, must be central to how we respond to eating disorders, particularly for children and young people. That is why we are also providing £13 million to strengthen the role of mental health support teams in schools and colleges through enhancements, so concerns around disordered eating and body image can be identified and addressed much, much earlier. Acting sooner improves outcomes, reducing the need for more intensive treatment later on, and helps ensure our young people get the support they need at the right time. Ms Vaz, while we are encouraged by the progress being made, I am under no illusions. I know that sustained improvement depends on clear, consistent expectations for high-quality care across the whole of the pathway. This is why, alongside the 10-year health plan, we are developing a modern service framework for severe mental illness, which I can reassure the House, which will include eating disorders and to help reduce avoidable harm from them and improve outcomes from persons affected by them. But to get this right, we need expert input across the system. So my noble friend, the Minister for Mental Health, will be hosting a roundtable discussion with eating disorder charities, clinicians and those with lived experience to ensure that modern service framework delivers meaningful improvements for people with eating disorders with lived experience at the heart of it. Ms Vaz, we spoke quite rightly about the online safety issues and as they intersect with mental illness and eating disorders. As a parent, I of course remain deeply concerned about the widespread availability of harmful material online promoting eating disorders, suicide and self-harm, which can be far too easily accessed by people and young people that may be vulnerable. The UK Online Safety Act 2023 makes platforms including social media, search and pornography services legally responsible for keeping people, especially children, safe online. All providers must mitigate the risks of illegal harm on their services, and all providers of services are likely to be accessed, and all providers of services that are likely to be accessed by children must take steps to mitigate the risks to children, especially content related to eating disorders.
He's very generous with his time. I've mentioned it in my speech, and I see it across the board, not just with eating disorders. The Online Safety Act makes provision that Ofcom can intervene, but only if the content is reported. So often very vulnerable people, we are relying on very vulnerable people to report something before Ofcom even intervenes. That cannot be right. There has to be a stronger emphasis on the social media platforms to actually take down accounts very quickly, and as I've also said, make sure that they don't reappear just under a different name.
My honourable friend makes a really valid point, and she will know, as I do, that the regulation of these platforms in relation to children's access is a very live issue at the heart of government at the moment, and she is right. The current provisions are not strong enough to be adequate safeguards. We do need more proactive intervention from our technology partners, and that is something that I know my colleague, the Right Honourable Member, that is the Secretary of State for the Department of Science and Technology, takes very seriously and is pushing very, very hard on, not only in relation to harm in this space, but harm in general for children online. Ms Vaz, Ofcom ensures that services uphold these duties include smaller online sites too. Its Small But Risky Sites Task Force has assessed 20 services relating to this harm, specific harm, over half of which have been at the high risk end for eating disorder content. And I'm very happy to write to my colleagues in the Department of Science and Technology on the back of this debate to learn from them what further action is coming down the pipeline, specific to eating disorders, and I can relay that to honourable members assembled in this House today. Ms Vaz, I also share the deep concern about reports of people with eating disorders being offered end-of-life care. The Royal College of Psychiatrists...
Dr. Scott.
I just want to go back to the digital platforms before we move on to end-of-life care. I think it's great. I really welcome that the offer for the Minister's given to reach out to the Department of Science and Technology to better understand what they're doing. But I expect that many of the people who are going to respond to the consultation around the banning of social media for people who are under 16 will come from the healthcare profession because of the connection between mental health, eating disorders and use of these platforms. So will he also proactively be asking for action just to make sure young people are protected? And also it's going to hopefully mean there's more resources for people who do have eating disorders because hopefully fewer people will be coming forward.
I'm grateful to my honourable friend, the member for Edinburgh South West, for that intervention. He's absolutely right. Being proactive and following the evidence should be our North Star when we're formulating policy, and I know it is that when it comes to my right honourable friend, the Secretary of State for Science and Technology. Ms Vaz, I was saying the Royal College of Psychiatrists have been explicit about eating disorders and end-of-life care. Anorexia nervosa is not a terminal illness in its own right. Its medical emergencies in eating disorders guidance was developed precisely to ensure that preventable deaths become a thing of the past. And NHS England is clear that no patient with an eating disorder should routinely be placed on palliative care. Our focus must always be on treatment, recovery, and of course underpinned by hope of recovery. We also share concerns about the accurate recording of deaths where eating disorders may have been a contributing factor. My honourable friend for Bath today outlined some of our frustrations in regards to correspondence with the Ministry of Justice, and I'm very happy to also take up that calling on her behalf with the Ministry of Justice to make sure she gets the correspondence that she is rightly entitled to. Ms Vaz, the Statutory Medical Examiner and Coroner system provides a clear framework to ensure deaths are appropriately investigated and recorded so that lessons are identified and patient safety is strengthened. Although, of course, it is for the coroner to exercise independent judicial discretion to determine what is recorded on the medical cause of death, I can reassure honourable members present that the Coroner's Office has been undergoing training to ensure that recording of deaths associated with eating disorders is done in a much more accurate and a much more proactive basis. Accurate recording, of course, matters, and we will continue to work with our partners, including colleagues in the Ministry of Justice and clinicians, to ensure not only the statistics are captured, but the learning underpinning those statistics are also reflected in improvements, genuine improvements to care. Ms Vaz, eating disorders are serious, complex mental illnesses that can affect anyone at any age, in any community, and indeed in any family. They require timely treatment, skilled professionals, of course, but sustained support thereafter.
I'm very grateful to him for giving way, and I know he's probably just about to draw his remarks to a close. I just wonder if I could just press him again on the mental health investment standard. It should ensure that the proportion of NHS spending on mental health goes up every single year. The last year we had numbers for it had gone up as a proportion of ICB spend, but had fallen as a proportion of NHS spend overall. Can he commit to us that the department won't be abandoning that standard and that we will see mental health spending go up each year?
I can certainly commit to the Honourable Lady that mental health spending in real terms will go up every single year. It went up by £688 million this year in real terms. And the good nature of this debate permits me only to gently push back on my opposition member when she talks about spending in the NHS. But I do feel I do need to push back a little and say one of the reasons that percentage in statistical terms is lower, but actually in real terms the spend is higher, is because we had to spend so much more money in the other part of the health service to compensate for the decay and decline that we've seen in the NHS over the last 14 years. That record £26 billion that was afforded in additional spend by the Chancellor in the budget. But she has my commitment in the overall philosophy that mental health spending will increase year on year. Ms Vaz, as I was saying, eating disorders are of course serious and complex, but they also require over and above skilled professionals, compassion, understanding and collective responsibility. Though the 10-year health plan, we are shifting care closer to home, strengthening early intervention, expanding the workforce where necessary, such as with community health, mental health workers, improving standards, and investing in community services that makes that recovery possible. We're also equipping staff with the right training, protecting young people online, and continue to improve the mechanisms by which we can do that, and explore the mechanisms by which we can do that, and working with experts and those with lived experience to ensure that the reform we are choosing to go down delivers real and lasting change. Ms Vaz, we know that the policy framework alone is never enough. Change also depends on the voices of campaigners, many campaigners that are here today and joining us, clinicians, families, and those who have shared their lived experience on the floor of this place today. Their advocacy, I can assure everyone, continues to shape this government's approach, and it will continue to do so. To those living with an eating disorder and to the families supporting them here and those watching outside, I want to say this. You are not invisible. You are not alone. This government is committed to building a system that responds with urgency, expertise and compassion. Our task across this House and beyond it is to ensure that when someone reaches out for help, the system we create is ready to respond with urgency, expertise and, of course, crucially, hope. I once again thank honourable members across the House for securing this debate, and I look forward to continuing this work with colleagues across the House.
Thank you. Rural Hall has 2 minutes to wind up.
Thank you, Ms Vaz. I want to thank everybody today who contributed to the debate in such a thoughtful way. First and foremost, my thanks go to the tireless campaigners, the people with lived experience, their families, to have shared their stories over so many years. Without you, Eating Disorder Awareness Week would not exist, and the awareness has definitely improved. But I want to repeat my frustration that while there is greater awareness, the outcomes for many, many people who are suffering from this tragic and devastating condition has not improved. And I know this now not so new Labour government has got a massive task in front of them to transform the NHS. But if their 10-year health plan would be meaningful at all, everything that applies to eating disorder services absolutely applies to the 10-year health plan, shifting from crisis treatment to prevention, shifting to community care, shifting to parity of mental and physical health. All of those, if the government wants to actually show that their strategy is working, they can show that through eating disorder services and the improvement of outcomes. Currently, the tsunami of need is not met by the services that we have. That needs to shift. Last year I said I was hopeful that 2025 was going to be the year in which we could change something. I haven't seen that. I will not make that same prediction in 2026, but I will say to the government, please listen very carefully to our call for an eating disorder strategy. I do believe that joined-up thinking would make a real difference, and the government could show through the improvement of eating disorder services and final outcome for those who are affected by this devastating condition, that their plan is working. Develop a strategy and implement the 10-year health plan to eating disorder services. If we see the outcomes and we can measure them properly, I believe that this government is turning a corner for the NHS as a whole. Thank you.
Thank you. The question is that this House has considered Eating Disorders Awareness Week 2026. As many as are of that opinion say aye. Aye. Of the contrary, no. I think the ayes have it. Order. The sitting is suspended until 3 p.m.